just announced, I'm Amanda Reddy. I'm the Director of Programs and Impact with the National Center for Healthy Housing, and I'm really, really delighted to be here today, partially because I'm usually charged with giving like a data presentation or explaining Medicaid to folks, and I have to sneak in a call to action, so it's just a luxury to actually be able to get up here and have that be my charge, is to really provide that call to action for all of you today. I've been working on healthy homes issues and asthma in particular for about a decade now, and most of that time I spent right here in Region 2 in New York State, where I focused most of my time working on the issue at hand today about how to increase access to and sustainably finance comprehensive asthma services that address the asthma triggers in the home environment. And at first, I'm going to confess to you, it was just a job. It was a way to pay my student loans after grad school. But when you work in this field, you begin to hear stories about the impact of asthma on individuals and families and communities. And like for so many of you, that job quickly became a calling. For me, one of the stories I remember early on in my career was meeting the DeLuca family of Orange County, New York. And I'll never forget sitting across the table as Mike and Erica DeLuca described the night that their 7-year-old son, Michael, died of an asthma attack, despite them doing everything they had ever been taught to treat and respond to their son's worsening asthma. Their story really, really broke my heart. But what was even more heartbreaking was learning just how common it all is. 9 people die every day in the U.S. due to asthma. 9 people. That's a shocking number, or at least it was shocking to me when I first learned it. But it doesn't even begin to tell the full story about asthma in our country. As we've heard from others today, asthma affects an estimated 1 in 12 Americans. That's about 25 million U.S. adults and children. It accounts for about 2 million emergency department visits, close to 500,000 hospitalizations, 10 million missed days of school, and 14 million lost days of work among employed adults. All of that adds up to an estimated $56 billion every year in asthma-related costs, with about $50 billion of that in direct medical costs alone, the issue that we're talking about today. We also know that burden of asthma is not equally distributed, that some of our communities share a disproportionate share of that burden. There are long-standing racial, ethnic, economic disparities, not only in who has asthma, but who has access to these comprehensive services that make it possible for asthma to be well managed and controlled. For instance, among people with asthma, Black children are twice as likely to be hospitalized, more than twice as likely to have an emergency department visit, and 4 times as likely to die as a result of asthma compared to white children. 16.5% of Puerto Rican children have asthma compared to only 8.2% of non-Hispanic white children. And those patterns, those disparities exist when we look at all kinds of outcomes and for all different kinds of groups, and importantly for adults too. A lot of the focus of many of the work of people in this room has focused on children, and that's important and it makes a lot of sense, but there are adults that have asthma also. When I was in New York State, I worked a lot with the data here, and I can report that for adults over the age of 25, accounted for about 65% of the asthma hospitalizations in New York State and about 77% of the costs associated with those hospitalizations. So also an important community whose needs have to be served. These are really costly and significant problems for our healthcare system in society, and ones that we really can't continue to ignore. And it's great that we have this event here today to get this conversation going if we're really serious about achieving the triple aim of increasing access to quality care, improving health outcomes, and containing costs. At the National Center for Healthy Housing, where I work, we're really interested in understanding how housing quality contributes to those disparities and to the problem of asthma, but also, and very, very importantly, and how housing can be part of the solution. In the case of asthma, we know that asthma can be controlled, that many attacks, hospitalizations, and deaths can be prevented. We also know that the disparities in asthma outcomes we've been talking about today are often mirrored by disparities in housing quality, that increasingly the zip codes where we live, work, and play are becoming just as important to our health outcomes as our genetic code. Housing that is full of mold and cockroaches and other asthma triggers really can make it impossible for people to control and manage their asthma, even if they're doing everything else right. But fortunately, because of close to 2 decades now of research and demonstration projects, we also have a really strong and compelling evidence base of what works to create healthier home environments for people with asthma. Multiple studies and demonstration projects have established that there are very low-tech and affordable interventions that we can put in place, that we have the infrastructure to put in place right now, that not only reduce the number of hospitalizations and emergency department visits and provide real savings to our healthcare sector, but also ensure that children are able to go to school and parents can go to work. And I want to be clear and just re-emphasize what we've heard today, that we aren't talking in many cases about thousands and thousands of dollars per home. We can have this kind of transformational impact for as little as $600 per home in some cases, or from Dr. Krieger, we heard $1,300 per home. And for the families that receive these services, it really is nothing short of a transformation. I know that many of you in this room have heard from families and patients that have received services from your program and about the value and the impact that it's had on their lives. And these positive findings aren't just confined to the research setting either. There's been a sustained and now growing interest from healthcare payers across the country in addressing social determinants of health. And to date, those payers that have implemented programs to address triggers in the home environment have pretty much universally reported a positive return on investment, an increase in patient satisfaction, and a shifting of costs from treating worsening asthma to preventing it. So we have a lot of good reason to hope. But many Americans still lack access to these services, and there's a lot more work to do, as we've been talking about today. Last year, our organization conducted a survey of all 50 states about their state Medicaid reimbursement policies for home-based asthma services. And at that time, only 13 states that said that they had any policy or mechanism in place to provide coverage or allow for coverage of these services through their state Medicaid program. And in most of those 13 states shown in red on this map, including New York State and Region 2, services were only available on a very limited scale. In some cases, not at all, right? Having a policy in place doesn't always translate into services on the ground. Or it could be that a single Medicaid managed care plan was providing services, or that the scope of services they were able to provide was really limited. Maybe they were able to do assessment but not actually help the family with addressing the triggers, or they weren't able to pay for all members of the care team, as we've been talking about today, the really important, critical role of community health workers. So again, most Americans with asthma do not currently have access to these evidence-based services, which incidentally, as Desiree reminded us, are also recommended as part of the clinical guidelines for best practices in asthma care. There are many, many reasons that access to these services have been limited. And while I've been at this for a decade, I know there are many of you we've heard from already today who've been at this even longer and are all too familiar with the persistent disconnect between the fact that we have the tools to help solve this problem. We know what works, and yet we still can't just quite figure out how to increase access, how to bring these services to scale, and how to really make them an integrated and sustained part of asthma care in this country. However, I also think we have some good news. Recent healthcare reforms, greater emphasis on preventive services has really rekindled that old interest, sparked some new additional interest, and there are lots of conversations like the one that we're having in this room happening all around the country. It's been really tremendous to see. In that same survey, where 13 states told us that they had some mechanism or policy in place to pay for the services through their Medicaid program, an additional 3 states said, not yet, but we expect to have services in place in a year. And since that survey, we've seen some of that materialize, with Missouri, as we heard from today, being the newest state to put some services in place. And even more telling to me was that 19 states, those are the ones with blue dots on the map, 19 states told us that they were actively pursuing either expanding existing services or putting new services into place. And that includes both New York and New Jersey in this region. And I can tell you, if we did this survey again today, the map would be even more populated with blue dots. The momentum is definitely on our side. The conversation is happening and moving forward. And for those 19 and counting states that said that they were interested in expanding services, there are steps that can be taken today. We've heard some ideas already put on the table today to ensure that more people have access to these services. I also know that at the National Center for Healthy Housing and many of the other federal partners in this room and elsewhere, including EPA and HUD, HHS, our partners at GW, who I have to mention have been partners in this work with us at NCHH, GHHI, Health Resources in Action, too many to even count. We've really been working hard to figure out ways that we can support states and healthcare payers, housing providers, other stakeholders, as you're really looking for innovative ways to partner and sustainably finance these types of home-based services. And so what we bring to you here today, you've heard some of it and you're going to hear more in the next panel, are stories from all around the country about what's working and what's not working, but really importantly, what's working to break down the barriers and really move past those disconnects. We also, though, have in the room today, and I just want to say how tremendous that is, and we've seen it demonstrated already, a really incredibly rich history of initiatives from this region that have been leading the way for many, many years, from the Monroe Plan's award-winning work of over a decade ago, all the way up to the current DISRIP initiatives that are being planned around the state, and too many to really even count or name in between. I was sitting in my seat on my smartphone, tried to look up the award winners. I think you have at least 4 or 5 EPA national award winners from within this region, which is really quite tremendous. So our charge here today is to really draw on that national momentum, the stories that the federal partners in this room bring to the table, and the rich history, experience, infrastructure, and really unique opportunity that exists in this region right now, so that we can forge new connections that help us to transcend the repeated demonstration projects that come and go in communities, and really begin to put in place services and systems that will protect the health of generations to come. It's really, really hard work what you're in this room to do here today and in the months that will follow, but we also know that it's possible. And I don't have to tell anybody in the room here today that for the families in this region that have asthma, for the healthcare systems and education systems that are chronically stressed by poor management of this disease, that the need is real and that the stakes could not be any higher. But I hope as we move through the rest of the discussion today and in the months that follow, as we have discussion and discussion turns to action, it will be with the understanding and commitment that so is the opportunity. Thank you very much.
I asked Amanda, Ms. Reddy, not to go because I didn't know if there were any questions that you wanted to ask her, because she's really an amazing resource. And you know what? I heard you in Philadelphia, and I was so excited. We were so excited that you could come here. So please feel free to answer questions.
Sure. It really is like coming home to me, so thanks for having me.
Hi, Amanda. My name is Steve Morgan with Clean Energy Solutions, and I wanted to also credit what you didn't say. Jonathan Wilson and David Jacobs have worked with myself, New York City Housing Authority, local foundations, to try to demonstrate that there's a whole other set of sustainable revenue streams associated with combating asthma in low-income neighborhoods, particularly in housing authorities, but all across affordable housing. One of them is called Energy Performance Contracting. It's a program that spends more money on asthma mitigation measures than the entire Healthy Homes division. Unfortunately, the Healthy Homes people don't know that. There's also an Environmental Protection Agency program just announced in August called the Clean Energy Incentive Program that promises to spend double the amount of any other investment, up to 300 million tons worth, for investments in low-income communities to save carbon, which means energy efficiency, which means ventilation measures, it means envelope measures, it means sealing cracks, and so on. That is much larger than EPA pays for anything they're doing in healthy homes, and I bet the people from EPA don't know this program exists. There's also demand response opportunities to get paid from utilities. There's utility incentives. There's something called frequency regulation offered by independent system operators. There's renewable energy credits. If you stack all of these on top of one another, you're talking about $2,000 or $3,000 per unit, so that you can afford to pay for those community health workers, which, by the way, don't have to be licensed if they're not paid by Medicaid. So if you layer Medicaid reimbursements with these other streams that address the building and not the household, you can have an incredible impact to make sustainable what we're all trying to do. Thank you.
Sure, I couldn't agree more or have said it better. In the follow-up to our survey results, I've been working with the folks at GW, you'll hear from Mary Beth Hardy on the next panel, to do case studies in states that said that they had policies in place. And one of the questions we're really digging into is how those different funding streams really work together to amplify the effort and sort of provide the entire range of services that are needed. So I think that's an incredibly important point. We heard from Amisha this morning the importance of braiding and really understanding that we're asking the healthcare sector, I think, to be a partner at the table, that we're not going to be very successful, I think, if we just try to shove this burden onto them, that we really just need to start working together across those silos. So thank you for that point.
Hi, Deborah Nagan from the New York City Health Department Healthy Homes Program. So I just wanted to kind of make one comment. This conference and this call to action is really focused on one particular thing, as to, kind of trying to get reimbursement for in-home services for asthma. But the thing that I'd like to say to folks is that it does seem to me that one part of that, once we're able to get that, is also a recognition that there's a bigger piece to this. There's housing quality. And there's a way in which we need to, even if it's referrals or whatever, try to change policy and actually expectation. We shouldn't have rotten housing. We have pest control policies in New York City where pests are a major asthma trigger, where the going way is through pesticides. So I think it's amazing that we're focusing on this one thing, but I think it's also an opportunity to think about other issues and other coalition kind of work that really can change and influence a change in housing quality so that we don't have people getting sick because of the places that they live. And I think this is a beginning to sort of bringing those folks together, and there are a lot of folks in the room working on those things, but you really can see a connectedness, and I think the National Center has been amazing at trying to pull those things together and make those connections.
Well, thank you again, Deb, for reinforcing that point. I couldn't agree more. And I do think it even makes our conversation with the healthcare sector richer when we're able to go and say, we want to put these services in place in a really supportive policy environment so that if we find these really intractable problems, they have somebody to call at the health department or the building department, the codes, and know that it's going to be followed through on. So it definitely... Absolutely. Couldn't agree more. If I had decided to use all of my 30 minutes rather than try to seed it for discussion, I could have told you about other initiatives that are going on at the center and elsewhere. But definitely this conversation is happening in a lot of sectors, and I think it's great that days like this get to bring everybody together to talk about it.
Hello? Oh. I wanted to ask about the map that you showed with the 19 different states. We know that asthma is, a big part of temperature, weather. Certainly pests are different in different places in the United States. It looks like a lot of these programs are in blue states, in colder states. Do you have any sort of comment on the different states that have decided to put policies in place based on their locations?
That's a great question, and one that our executive director at the time when we published this report asked me, and so we tried to make sense of it, and again, like I said, this map was outdated almost as soon as we produced it, so we've seen more action and momentum happening in that mountain time zone area that looks so gray on this map. And we really couldn't find actually patterns. We tried to look at, in terms of when policies were in place with the political landscape, who adopted Medicaid expansion versus had these policies in place. We had a similar survey for lead poisoning services, so we looked at it for both surveys, and we didn't see any striking patterns really emerge there. And for asthma, the momentum really seems to be spreading across those types of boundaries. And I will say, if you are interested in the results of this survey, which tells a lot more detail also about what's included in the services, what types of workers provide the services, much more detail than I would have time for today, you can follow the link there. You can also get state-specific information about what your own state said. Okay, great. Thank you so much.